Good morning, ladies and gentlemen. It really is great to see so many delegates here at our Rural Health Conference. I know that the commitment that you bring to rural communities, and I really do appreciate the sacrifices you make to look after the engine of the New Zealand economy, the people of rural New Zealand. We're extremely pleased to see such a strong turnout at this conference, given the challenges facing rural health professionals at this time. Our collective strength and advocacy has never been more important as more and more of our health force reach retirement age, placing greater and particular pressures on the delivery of rural health services. As it stands, half of all New Zealand doctors plan to retire in the next decade. Rural doctors are working longer hours than their urban counterparts and are spending more than 1/3 of their time on call compared to urban doctors. They're typically a little bit older too, meaning the crunch will hit rural communities faster and harder. Now, I'm quoting statistics for doctors here, but I want to stress that this equally applies to our highly valued rural nurses. Wherever you look across the rural health landscape, the pressures are rapidly mounting. This morning, I just want to talk briefly about 3 core issues which our organisation is going to focus on with your support over the next 12 months. And then I want to introduce our very special guest speaker, the Minister of Health, the Honourable Dr. David Clark. By way of our first priority, the team at New Zealand Locums will continue to deliver on our contract with the Ministry of Health. We go out and recruit doctors to rural positions, and we will continue to do that with commitment and passion. It really is this government initiative that is keeping many health services in our rural communities afloat. And the team at New Zealand Locums does an exceptional job of attracting and bringing doctors from all around the world and from within New Zealand to work in rural New Zealand. Secondly, during this conference, we will hear from the advocates for the Waikato University Rural School of Medicine and the Otago and Auckland universities on their network of rural health schools. The process around these proposals is an important issue for our sector, and I know there is a huge interest in them from all quarters. It has become increasingly apparent that perhaps the solution might be or might lie in cooperation rather than competition. I personally know the people behind these proposals, and I respect them. There is absolutely no doubt in my mind that both these proposals are generated by the intention of significantly improving rural health outcomes. They are good proposals, put forward by good people. But I cannot help but wonder if the competitive model might not be working in the interests of rural people here. Instead, I ask what it might look like if these universities were able to come together and collectively, using their resources, their expertise, and geographic reach, develop a single proposal that, in partnership with each of you here today, would deliver more than the sum of its parts. This is not a criticism of either proposal, rather an observation that I believe solutions must be driven by grassroots practitioners, and that we will only succeed when we are united rather than in competition with each other. Finally, and I have made this point directly to the Minister, so do not mind raising it again in front of him, we need to urgently change the way we fund prime emergency response services. To fund a national 24-hour, 7-day-per-week emergency first responder service across 75 rural regions of New Zealand for 1.8 million is just not sustainable. The chronic underfunding of this service is placing far too many demands on many of you. And you have to keep this, or are trying to keep this essential service, but it won't be able to happen if more money is not forthcoming. You will simply be unable to deliver the care you are charged with providing, in which people, locals and tourists alike, expect and deserve. For a modest doubling of the $1.8 million, we could adequately fund this critical national emergency response service. It would be less than $4 million per year, and that has to be outstanding value for our money. Our organisation, the network, will continue to push for this funding imbalance to be urgently addressed. So on behalf of, and we will address it on behalf of the prime responders who already give so much to rural New Zealand. I know that the new Minister for Health, the Honourable Dr. David Clark, is also committed to causing things to be different. That is not a partisan comment, as I know full well that nobody takes on the role of Minister of Health without the very best of intentions. But over the decades, intentions have not been enough. And it is with this context that I believe Minister Clark has taken on the toughest and most challenging portfolio in the new Cabinet. I know you are all very keen to hear what he has to say on some of the issues that I've discussed with you this morning, and what his view is about the delivery of primary care and rural health services, both now and over the next decade. Minister Clark, thank you for joining us today. We really are committed to continuing a strong and constructive relationship with you in support of delivering equitable healthcare services to rural Kiwis. I invite you to address our conference.
Te hei Māori ora. Tēnā koutou, tēnā koutou, tēnā tātou katoa. Ki te atua me whakakoroia tōna ingoa i ngā wā katoa. Ki te whare nei, the grand old Pullman, tēnā koe, tēnā koutou i au tātou tēnei mate haere, haere, haere atu rā. Ap te hono, tātai hono, i te iwi, tēnā koutou. Ki ngā tangata whenua, e ngā waka, e ngā reo, e ngā mana. Nō reira, tēnā koutou, tēnā koutou, tēnā tātou katoa. I am indeed David Clark, your Minister of Health. And thank you, Dalton, for the introduction. I just want to acknowledge it's a real privilege to be here, my first time here as the Minister of Health. I will make a few comments just at the start, off the back of your introduction. I'm on a relatively tight time frame, and I was going to leave some time for questions at the end, but I think it's better to address the things that Dalton has raised, because I think they are the concerns of the conference, and they're not covered as well in my pre-prepared notes as I'd like. I've only just got some of the briefings that speak to the issues following our meeting, Dalton. And can I acknowledge the fine job of representation that Dalton does, and also Network Chairperson Sharon Hanson on your behalf, the Network Board, Te Rupu, Arahi, and I want to acknowledge the overseas guests who are here as well. I also wanted to quickly just cover off, my speechwriters or drafters will be horrified as I go off track again at yet another speaking event. I really appreciated Susie's words about my words, not hers, about addressing the underlying social conditions in terms of infectious diseases. At the antimicrobial resistance, I was able to pop in, got here a bit earlier than expected to hear some of that. One of the things that the new government has done, which I don't think we've made enough of yet, is that we have put through a families package. Instead of tax cuts targeted primarily at the wealthiest New Zealanders, we as a government have taken a decision early on to put that money into a families package, which comes into play midway through this year. The Treasury tells us that is the biggest redistribution of incomes in New Zealand since 1991. And I just don't think we've said that yet. I wanted to let Adrian know as well that Latin's my third language. It's a long way behind the other ones. I failed that, I think, in both third form and fourth form. I don't know how I got into fourth form, even. And thank you for all of you, as an opening comment too, for the work that you do in our rural communities. And I acknowledge the challenges that Dalton raised, the ageing workforce. I think I got a briefing this week telling me that for the first time since 2009, the average age of GPs actually dropped in the last year. But we all know that we have a major, at very least, major distributional challenge in terms of our workforce that goes to nursing, to allied health as well. We have a significant challenge there, and that's something that I am determined to tackle, and that bridges a little bit into the rural school question. I have not yet received advice that I've requested from the Ministry in respect of that, but I wanted to let you know that as I understand the issues, that it's not rocket science to solve. Firstly, you need to recruit from rural areas. Secondly, you need to give people training opportunities in rural areas. Then, once they've completed qualifications, you need to give them opportunities for advancement in rural areas. And somewhere along the line, you need to address the capital question, because when people retire and perhaps there's a husband and wife or something that have been working there for decades and they've left an old villa, it may not be the thing that attracts a new medical graduate to a rural area. And as I understand, those are the basic things we need to tackle. It's my view that we actually need to focus on the GP training end of things. We have, in my view, sufficient people coming through. We have some great people coming from overseas, but what we actually need is to focus on the GP training aspect and making sure that we have good rural representation in that. And I acknowledge Tim at the back there for conversations I've had on that, and various others of you in the room who've at different times addressed this issue with me. In terms of the prime situation, I was reading the briefing I've got madly on the way from the airport here, Dalton, in response to our meeting last week. It's just come to me. And to be honest, the briefing hasn't yet answered all the questions that I have. But I think that's going to be an ongoing conversation between you and I. I understand that there was, I obviously wasn't a part of the previous review. It's before my time even as the Labour Health spokesperson. But there was a proposal put which was believed to be in line with what was requested, but the funding constraint really is the issue more than anything now. The actual, and you and I haven't had a conversation yet about the structure proposed and any issues with that. But that's something I'm interested in taking forward. I recognise the importance of the prime workforce. So to go back to what I'm supposed to be talking about, if there is time at the end, I'll take some questions too. I'm just mindful that I've got to be out of here, and Justine will keep me honest if I go too long. You will work in geographic isolation, and I want to acknowledge the challenges that represents, and the challenge that represents in respect of compared to urban centres. You are required to work at scope so much more often, dare I say it, than those at top of scope than many who are working in urban centres. And you represent the leadership that ensures sustainable services in our sector that meets the needs of local communities through the use of integration and innovation. Your experience and guidance is invaluable, I think, to the future of our health sector. And I'm taking as many opportunities as I can in the first period as Health Minister to get around and speak to as many groups as possible. I welcome feedback. I've asked for free and frank feedback. I have been getting it so far from this group, which is great. And as Health Minister, I see my job as representing the patient interest. So we might not always agree on everything, but I think we'll agree on a lot, actually. My basic belief is that we have the experience and skills in the sector to solve the challenges we have if we work collectively to solve them. My opportunity today is to share something of the government's vision for health, so that you know where I'm coming from and where my priorities are, where the government's priorities are, and how then from there we can work out how to work together to solve the collective challenges that we have. As by way of introduction, I wanted to also just talk a little bit about how I came to be involved in politics. I am based in Dunedin. I replaced Pete Hodson who was our former health minister, as the local MP when he retired in Dunedin North. In my electorate, I have the Dunedin Hospital and the Otago Medical School. And my previous roles at Selwyn College have brought me into connection with people in this room, both at Selwyn and Knox College often as well. And thank you to the graduate who came up and talked to me during the morning tea downstairs. So I have a long connection to health issues in that respect. But my main driver, I guess, is inequalities. I got involved in politics because I'm concerned about the growing gap between rich and poor in New Zealand and the impact that that's having on our society. The OECD put out a study in 2014 which indicated that that gap in New Zealand, we're not the worst in the Western world, but it's grown faster in the last 3 decades in New Zealand than in any other single OECD country. So we're not the worst, but we are on the track to be the most unequal country in the Western world if we don't do something about it. Now, I believe the families package we've just put through will start to make a dent in that. But I believe that's an incredibly important thing to do because it doesn't, for social reasons, economic reasons, and also for about who we are as New Zealanders, I don't think that inequity sits well with us. And I figured that I could either sit on the sidelines and complain about it, or I could get stuck in and get involved as a politician myself. And Dalton, I think you're right, this may be the most challenging portfolio, although I'm currently delegated to run the budget processes on behalf of the Finance Minister, and so I have a target not only on my back in public, but also in Cabinet right now, as my colleagues seek additional funding for this and that. But to me, the biggest illustration, or the most personal illustration of how those inequities have grown is in my own family. I grew up in Beachlands, not so far from here, and when I was about 9 years old, my father left his job with a reliable income in order to start his own manufacturing business with a friend of his. And about the same time, my mother went back to high school for a couple of years, and they had 2 children and a mortgage, and we had almost no household income for about 3 years, so we had quite a low household income. And they were able to do that. My mother then went on to become a GP, as it happens, so she's actually a real doctor. During that period, we had very low household income, and it's hard to imagine that happening today, 3 decades on. One person going back to school for several years, one person starting a business with no income, having 2 children to feed and a mortgage to maintain. They worked hard beforehand, they're talented people, they saved some money, and that was all possible then. And I think today, it's possible to imagine 1 or 2 of those things, but it'd be a real stretch, maintain a mortgage or a family, or one person in the family go back and train, or one person start a business, but not all of those things together. And in one generation, that has changed immensely in New Zealand, and I don't think that's for the better. So that's my background. That's what drives me, inequities. And so when I come to healthcare, I'm looking through an equity lens. That is my priority, and that's why I'm very interested in prioritising primary healthcare, mental health, and delivery of services through the public health system. All of those things have an equity angle to them. And I ultimately want our public health service to be one where social or economic background doesn't determine the quality of care that you receive or the health conditions that you're likely to develop. So my priority then is to build, and in some cases rebuild, a truly public health service that delivers the care New Zealanders expect and deserve. It's not about every person for themselves, it's about the community taking responsibility for each member. And that strengthening of the health service will be a touchstone for this government. Striving to be a world-class health service is always going to be front of mind, and that's why we pledged to put $8 billion into health over the next 4 years. Partly that was a political promise. We knew our opponents would not match that one. They wouldn't want to talk about it. It's also a clear signal of our priority in terms of looking after health. Now, I don't want anybody to get too excited about $8 billion because anyone who looks at the books will know that gets eaten up pretty quickly in the initiatives that we've laid out already. There is room for new initiatives, but enormous salary increases won't buy us a public mandate, nor will failing to introduce those things that we've campaigned on. So we've got a tightrope to walk. We've pledged to put more money in. We've pledged to build the sector and create a sustainable workforce, and that's what we intend to do. And if we needed any other example about the need for investment in the sector, the recent news about Middlemore underscores the need to invest in our public health service, and it shows the impact of a situation where health hasn't been funded properly. And I don't think that government can afford to take its hands off the wheel and allow those kind of situations to develop. I've actually asked for an asset management plan, which as I understand it, I'm the first Minister of Health to do that. It may turn out to be a courageous decision. I'm told it's too soon to talk about my political epitaph, but it may have something to do with that particular project that I've kicked off. I just think it's shameful that we as a country don't know what assets we have on the book in our health system and how we're going to replace them. So we have challenges, as we know. We've got a growing population, an increasing number of people living with long-term conditions, comorbidities, and an ageing workforce. And that means that we need a new generation of health professionals to take over the reins and change expectations New Zealanders have due to the opportunities of technology as well. I think we need to address inequities, notably amongst Māori, Pacific people, people with disabilities, people living in rural areas, and people on low incomes, and we all have a role to play in that. It's my view that we need to develop new ways of delivering health, and those ways are going to be more cost-effective, sustainable, and they will actually contribute to the quality of outcomes and the quality of services we're able to offer. I'm sure we can all here agree that the way primary healthcare is organised and delivered impacts on the functioning of the health system as a whole. So while the efforts of our doctors, nurses and allied health workers are enormous and highly valued, I don't think that the current service models we have in every case are working for everyone. And that's demonstrated for me in the inequities of outcomes that we have. Now, don't for a minute question the motives and the efforts being made currently, but the way the system is set up does not get us there at the moment. I continue to hear stories about people who come into hospitals who have conditions that should have been able to be managed in primary care. And that is something that I think we all need to address. And part of it's cost. We know that the healthcare surveys tells us that 500,000 New Zealanders in any given year can't afford to visit their GP for reasons of cost. So that's something that's 1 in 4 adults in New Zealand, and I do think that's a truly shameful situation to be in. So we need a system that prioritises primary healthcare better to improve population health outcomes. So to address this challenge, the government has planned a number of initiatives in the near future. One of them is a plan to invest in improving access to healthcare by addressing some of the cost barriers for high needs populations. In addition, we want to increase funding for GP training over the course of our first term. These initiatives will be an early investment while a review of primary healthcare funding as a whole is carried out. And the review itself will aim to ensure that funding and structures are right to support a modern and well-functioning health system that is built on accessible primary healthcare and is also fair to professionals, providers and patients alike. To deliver the workforce the health workforce that we need and the services that we need in New Zealand, we need to make sure that we have indeed the right workforce to deliver those services. Health workforce is developing a needs-based model that will inform our future thinking and planning. The needs-based planning model will examine both the distribution of health professionals and the needs of people in communities across New Zealand. By doing this, it's not just about counting heads, it puts people and their health needs at the centre of thinking. The patient must come first. It provides us with the opportunity to improve equity, identify areas of unmet health need, and understand and improve the distribution of health professionals to high needs and rural communities. This kind of work will help us develop ways of delivering health services that are more cost effective and sustainable so that we can continue to improve health outcomes and the quality of services. I think that technological solutions will have a part to play in this to make sure that all New Zealanders receive the same level of health care. Telehealth Services such as video consultations can provide people living in rural areas the option of remaining closer to home, making consultations more convenient and reducing travel. And a majority of district health boards, 17 I think from memory, have video conferencing capability. Usage does vary across the DHBs, but I understand the most common uses of video conferencing capability are for telepediatrics and renal care. Ministry of Health works collaboratively with a telehealth leadership group, which brings together experts to nationally promote the uptake of telehealth. And I'm encouraged to hear that more GPs are using video conferencing to consult with their patients and specialists. It means people living in those rural or remote areas can receive that same level of service that we'd expect for people living in the city. Of course, New Zealanders want to be more in control of their healthcare, and we can do this by ensuring more people have access to their own health information with the appropriate caveats around privacy and confidentiality. The use of patient portals continues to grow. I'm told over 500,000 people now have a registration on a portal, and 545 practices, which is now over 55% of practices. So I want to thank you all for the work that you're doing in that area, and thank you for the increasing use of those services and that technology. It will make a difference, I'm convinced, in our health sector. I'm told that I'm running out of time. Prime service I have touched upon. I'll leap over that section and speak briefly about mental health. We know that the unique challenges in the rural sector are significant in terms of mental health outcomes, and I'm keen to hear more about how we manage that over time. It is something that there's an opportunity with the inquiry into mental health that we launched in January. That is an independent inquiry, and it is set up so that it can, independently, so that it can make challenging recommendations to government. That's why we've done it that way. It effectively has the powers of a Royal Commission. It's a muscular committee. It has the ability to subpoena witnesses. It has the ability to present information anonymously that it receives to protect the identity of people who may feel that if they live or work in a small town or in a workforce where they feel threatened by revealing information about what's going on, that they can present evidence under that guise. It is incredibly important that we get a sufficient supply of rural voices to that inquiry. It's got very good people on it. It's due to report back in October. It's shorter than a Royal Commission because I think a lot of what we know already needs to be collated in one place. They are going to take into account previous work done in this area, and that's my expectation. But we need to have in one place, I think, a path forward that is challenging for politicians, but that recognises the very real mental health needs in our community currently. So in conclusion, I want to say thank you for the role that you play in primary healthcare. It is crucial to our health system, and I am very much looking forward to working with you as we tackle the common challenges we have. I hope you enjoy the conference, and again I'd like to thank you for the work that you do in supporting the health and well-being of our communities. Nō reira, tēnā koutou, tēnā koutou, tēnā tātou katoa.